All right, so welcome everyone to the Society of Thoracic Surgeons Congenital Heart Surgery Database Monthly Webinar. Today is Tuesday, March the 18th. Hope you all had a good St. Patrick's Day yesterday. Agenda today on the call with me, let's see here, we have, who do I have on the call with me today from the STS side of things? Where is my attendance? We have myself and Carol Crone, Banu, Chastity, and Leslie. From our consultant team, we have Emily Conrad, Nancy Honeycutt, and Paul Meehan. So thanks for joining me on the call today. For STS update, I just have a super brief update, and then I'm going to turn things over to Chastity and Leslie for our data manager education. And then, as usual, we'll finish things up via Q&A. If you have questions, please enter those into the Q&A. We also have the raised hand function enabled, so you are more than welcome to raise your hand and we will unmute you and just ensure that your microphone is enabled on your end. So let's go ahead and get started. STS updates. March training manual is posted and available out there for everyone. Our 2025 harvest schedule, as you all are aware, that communication was sent that we are extending the spring 25 harvest. I do not have the harvest close date as of yet. The harvest close was originally scheduled for March the 21st for the end of this week, but that is going to be extended. We are currently reviewing a little bit more of the feedback that we got from the release of the updated primary procedure mismatch report. So we're reviewing that last bit of feedback today, and I do plan on sending that STS communication about the harvest close with the harvest close date. I plan to send that tomorrow, so that will be coming this week. And as of right now, again, the fall 25 harvest close date is September the 26th. The primary procedure mismatch report, this is information that we shared last month. Again, that new process was effective as of January 1, 2025. The primary procedure assignment update is replacing exception 1, aka also known as that procedure specific factor rule. And all of these, the new rules, updated rules will be implemented in the spring 25 analysis. So these updated rules will apply to that 4 years of data. And we initially kicked off our education about the updated primary procedure rules back in November on the November monthly webinar. And I know, I think Chastity and Leslie are going to be providing a little more education on that today. AQO 2025, no updates from last month. Again, just a reminder for those that were not able to join us last month, the CHSD and GTSD sessions are going to be held on Thursday, October the 2nd. Our ACSD session will be held on Friday, October the 3rd, and we will be at the Grand Hyatt San Antonio Riverwalk. Reminder that the AQO session proposal deadline is April the 18th, so we would love to have you fill out an AQO session proposal. We would love to hear your ideas on if you yourself would like to present, if you have a topic that you would like to present, or things that, sessions that you would like to hear this year at AQO. So again, please fill out that session proposal. I do have a link to the proposal form out on the STS website. Also this year, we will be offering both the in-person and virtual options, just as we've done in the past. And the cost information for this year's AQO will be shared as soon as it is available. So more information coming. I think that's it in terms of AQO 2025. So if you have any questions, we are happy to address those. And that is all that I have regarding STS updates. Like I said, just super brief from my perspective this time. So I'm going to turn things over to Chastity and Leslie for our education.
Thank you, Leah. Thank you for the information about harvest close as well as AQO. I am here to talk to you with some education updates on some database discharge date information, as well as PDA ligation coding. And then Leslie is going to tie things up with some updates to the analysis. Next slide, please. So when we look at database discharge dates, we have some differences. Those of you who've been doing this for a little while realize, and if you've only been coding in version 623.2, then maybe you don't realize, but you have fields that were available in 341 that are different now in the new version of 6.23.2. So remembering back in 341, we have date of database discharge as well as the mortality status at database discharge, whereas in version 6.23.2, that date of database discharge and the mortality status at database discharge are auto-calculated based on what you complete in your discharge field. So with hospital discharge date, and is the patient still hospitalized at your facility or another, and we enter what's called now the end date of database tracking and the status at the end of database tracking. And dependent upon how you fill out multiple of those fields is when your date of database discharge date will auto-calculate for you along with that status. Next slide. So some important thoughts or things that you need to keep straight in your data files. So the database discharge dates and all of those database discharge fields, especially for your records in 623.2, do need to be filled out on every operative record. So we have an understanding that sometimes people are only updating this information on the index operation and not on all of the operations. And this is causing some trouble upon analysis. Also, this can be vendor dependent. We have come to realize that there are some vendors who only offer the discharge tab, if you will, one time. They then stamp all of the operative records. So a patient that might have, say, 3 operations during their episode of care, a vendor may stamp all 3 of those records with what you entered on one case in your vendor software. But again, that's vendor dependent. So technically this is filled out on every operative record in the database, regardless of whether it is the index operation or not. You want to make sure that you are very accurate then when you are completing this on every case, because as you know, all the operative records within your episode of care should have the same database discharge dates as well as database discharge status. So it would not make sense for a patient that had, let's say, an RV to PA conduit placement and then turned around a few days later and had a delayed sternal closure, that you have different database discharge dates or hospital discharge dates and or status. That's all under the same episode of care, and those questions are all answered based on the status and date at the end of episode of care. So if you're updating one of these operative records, say that your patient discharged and went to another facility, whether acute care or long-term care, you must update this for all of the records, all those surgical records, each of those cases in the episode of care, and not just the index operation. For those of us who complete this for every operative record, I understand, especially if you are, say, a transplant or VAD program, and perhaps you have 15 or 20 procedures on somebody, you're updating this perhaps 15 to 20 times, depending on the number of operations a patient has during their episode of care in your files or in your database. Next slide. So let's take an example of this and show how it can impact analysis. So you have a patient with 1 episode of care that's entered into your database, and they have these 4 procedures. So on 1-1, they admit, and on 1-6, they undergo a Norwood. The database discharge that is associated with this Norwood procedure was entered as 331. Then the second record shows an admission date of 1/1/24, a surgery date 1/7/24, and this is a mediastinal exploration. Again, the database discharge date was entered as 3/31/24. Then the third procedure, again, an admit date of 1/1, surgery date of 1/8. They undergo delayed sternal closure, and again, the database discharge date on that record was entered as 3/31/24, same as the ones above. Then again, the fourth surgery that occurred during this episode of care, an admit date of 1/1/24, a surgery date of 2/20/24, and they undergo a shunt reoperation. This time, there's a database discharge date that is entered of April 29th of 2024. Next slide. So based on the database discharge dates, analysis would look at this as 2 separate episodes of care. We know, looking at this and eyeballing it, that they all have the same admission date and would have assumed that there's an error here in the entered database discharge dates. But when those people that are crunching our numbers, DBA, they look at this as two separate episodes of care. So next slide. So obviously this will impact analysis in many ways. Surgical volume, you've just gained an extra case in your surgical volume, and episode of care at that. And so you're going to have incomplete or inaccurate denominators throughout your analysis report. Your postoperative length of stay would now be calculated for the Norwood operation in addition to a shunt reoperation, and that is incorrect. And then as well as your mortality calculations for survival and or mortality. And so great impact. And this occurred in a large number of operations in the database. So you want to make sure that you're reviewing your discharge fields for every operative record and not just the index operation. And we think that that's perhaps what it was causing this, is that you had updated information, and in a patient that had multiple operations, maybe a data manager identified the index operation and updated the discharge fields on that record, but didn't go in and complete them on all of the other records, thinking, well, they're not analyzed, they're not the index operation. But things like database discharge data are used to help identify the index operation and the episodes of care for the patient. So every record needs to be treated equally and all updated. It's also very easy, and another thing that DBA was able to see in the files were more like keystroke errors, that I knew it was March 31st, but I accidentally entered March 13th on one of the records. And that's problematic as well. So you just want to have some type of mechanism in your vendor software to be able to look at all of your discharges. So it really depends on how your vendor handles this and how it looks on your screen. So, you can talk with other people to see what they do to, pull out their discharges and look at them in batch to make sure this is accurate for those patients that have, multiple. I find this when, I have a patient with 15 or 20 bad procedures and things, that is more likely where error would occur. So again, you want to have a process for this and some way to look at this to make sure that your analysis is accurate. Next slide. Okay, so moving on to the next topic, which is about our PDA coding in the database. So many of you probably already know, and I'll take you back to your physiology classes, but what is the ductus arteriosus? And so this is actually a fetal blood vessel that connects your pulmonary artery to the aorta during your life as a fetus to shunt blood away from the lungs, because of course the baby's lungs don't need blood flow in the fetal period. So that's what that vessel is for. Following birth, we know that this vessel should normally close within a few days. However, we work with a population where this often may not happen. But when the vessel closes, there's remnants that are left behind, and it's really a non-functional fibrous band called the ligamentum arteriosum. And so I'm sure you've seen this in your operative notes over time when they talk about the ligamentum. Next slide. So following birth, if this blood vessel, the ductus arteriosus, fails to close, we now have what's called a patent ductus arteriosus, PDA, and it allows for a continued shunt in our hearts. And this is common in premature babies and can lead to heart failure because you're getting too much blood now pumped into the pulmonary arteries, and the heart isn't able to handle that load over time, which is why we would go in and close the patent ductus arteriosus. Next slide. So back to the ligamentum. So when the ductus does close, what then is the ligamentum arteriosum? And I tried to find some pictures of this, but it can be problematic later. It's non-functional, and for most of us, it probably doesn't cause any trouble. But when you have anything else going on in your heart or lungs, then this ligamentum can cause trouble. So we see this often involved with vascular rings and coarctation defects in our patients. And so then it may require ligation as a part of those, or perhaps even in other procedures, you're seeing this in your op notes, that the ligamentum had to be clipped or ligated. Next slide. So back to how we would code these in our database. We have two procedures in our procedure section for the closure of a PDA, a patent ductus arteriosus. So we have procedure 1330, which is the surgical closure of a PDA. And this is by any surgical technique, ligation, division using a clip, by any approach. So a thoracotomy or thoracoscopic, median sternotomy, however we are doing this, all of it goes under the PDA closure surgical. It does have a stat score of 0.2 and category of 2. There's then procedure 1340, PDA closure device. This does not have a stat score, and the definition in the database is that this is closure of a PDA by device using transcatheter techniques. So this is what we have to code. And what you do know about this is that there are now combination codes where we do PDA surgical closures in combination with other procedures. So it's important that we are coding our PDAs correctly. Next slide. What you do notice in both of these definitions is that this does not include the ligation or division of the ligamentum arteriosum. And so this will be updated explicitly in the training manual since it does not say that currently. Next slide. Actually, I think it does in March. It didn't say it prior. So if coded as PDA closures, it impacts analysis and could result in inappropriate combination code creation. So you want to make sure that if you are actually coding the closure of a PDA, that you actually have a PDA and that it's not the ligamentum. So do not code the ligamentum arteriosum ligations as PDA closures. For those of you who code using the quote unquote short list or the STS list, this is not a problem. You don't have a code for the ligamentum. However, if you are a program that uses the long list and you select ligamentum arteriosum, it is incorrectly mapping to a PDA ligation. There is a way to work with your vendor to deactivate that code so that it no longer is available for you to select. This may be helpful if you have multiple people who code within your database and or surgeons who like to code in your database and they're looking for that ligamentum. Of course, in that software, you have to hover over the term to see that it's mapping to PDA, and that's what we're trying to get away from. You want to code then, understood that we want to try to capture when we're removing the ligamentum. And so for now, you're going to code this as procedure 2010 cardiac procedure other. We want to make sure, because otherwise IQVIA is going to give you something back that says, oh, these ligamentums, which are being mapped to PDA closures, you should actually be using these combination codes, which are not appropriate in this scenario. Next slide. So this is what the training manual looks like. It was updated at the beginning of March, but it now says does not include the ligation or division of the ligamentum arteriosum. Instead, code procedure 2010 cardiac procedure other. Next. And I think that's it for me. I'll turn things over to Leslie.
Great. Thank you, Chas. Okay, we're going to do a quick analysis. Well, not really quick. It's like 10 minutes, but an analysis update. These are not new things. This is how the analysis has worked. However, because we had a large number of procedures kind of reallocated into our primary procedure mismatch report, we got a lot of questions about how did this combination code come up, how I have a tie and what's happening with my tie. So we wanted to just touch on these two subjects and give a little bit more context going into the next analysis. Next slide. Okay, for background, when your codes come in, all individual codes that you have listed are considered in creating combination codes. And all possible combinations are created, meaning if you have a code listed one time, but it could be a part of two different combinations, it still will create whatever applicable combinations and use that code however many times it needs to, and move forward. So all possible combinations are created and the components that make up those combinations are then just sort of ignored. They're not removed, they're still there and kept in our data, but they're not considered when looking for a primary procedure. Of course, this is all explained in the analysis overview, which is available online. And if you have been doing this a while, you probably remember when Chastity and I used to do the new data manager talk as a part of AQO, we used to harp on this analysis overview over and over. When you get your report, look through that, make sure you understand how these things are done. We want to say the very same thing now as well. That analysis overview document is gold. That will tell you how these things are happening. So make sure you're reviewing that when the reports come out. Take, a half day if you can and really go through those 50-ish pages to make sure you understand. We have been working really hard to give analysis updates prior to a harvest close when we know things are coming, but that's not always the case. And so that document will explain what has happened in the most recent analysis. Okay, plug over. And then combo codes and any other individual codes that weren't included in combos are then considered when determining primary procedure and kind of going through that logic algorithm. Next slide. This again is listed in the analysis overview beginning on page 5. It says some procedures will be mapped to available combination codes. The individual procedures that make that up are not removed, but just remain. And they are not considered for primary procedure determination. For a list of the combination codes, please see the website. This is actually now embedded in the analysis overview. Next slide. So beginning on page 34, it will talk about the combination procedure codes that we often talk about on these calls. It goes through each one and it goes through which codes are included in those. That is different than just a procedure that has multiple components, and we will talk about that in more detail on a future call. This is combination procedure codes that then are made up of other procedures with their own unique codes. And again, that starts on page 34, of the analysis overview. Next slide. Okay, so to go through an example of this and how combination codes are formed, if a data manager codes 830, 3540, 3680 for the Sano shunt, and 870 for the Norwood procedure. Next slide. Then the logic says, hey, these two codes are part of 5005, a mitral or systemic AV valvuloplasty and an aortic valvuloplasty. And this has a slightly higher stat mortality score and puts you in a different stat category. Next slide. It also picks out that 830, 3680, and 870 are a part of another combination code, 5012, the Norwood plus systemic AV valve plus Sano shunt, again with a higher stat mortality score in category 5. Next slide. So now these two combination codes, 5005 and 5012, are then moved forward to consider for primary procedure determination. The individual codes are not considered. And in this example, there's no other individual codes that would be considered. So in this, then the 5012 being the highest stat mortality score without meeting any other rules and exceptions will be determined as primary procedure. Next slide. So you can take that code 5012, now you know that's your primary procedure, and you can see that it's still going to appear in your benchmark table. And next slide. It'll still appear in your lesion specific table. Next slide. But you could have different codes that come out of this, and this is based on how you've coded these procedures. So say the data manager, instead of listing everything individually, the data manager lists 5005, that combo of the systemic AV with aortic valvuloplasty, as well as the Sano and the Norwood is included as well. Now these codes are moved forward. There's nothing to break down a combo code coded on its own into individual components. So there's nothing to say that this should have picked out a 5012, for instance. And then based on these codes and the current procedure algorithm, the Norwood procedure is going to be primary. It's the highest stat mortality score without any other rules or exceptions. Next slide. And again, this will be both in your benchmark and in your lesion specific table. Of course, your lesion specific table is based on diagnosis as well. I didn't screenshot that here. But in this example, more than likely you have the same diagnosis. So no effect, it's in there for both procedures. Next slide. Well, we want to look at another example. In this one, the data manager has submitted 110 for a VSD repair, 20 for an ASD repair, and 580 for a conduit re-op. Next slide. So they picks out 5001, which is your VSD plus ASD, and this is your still stat category 1. Next slide. It also picks out 110 and 580, a conduit reoperation. And this now has an even higher stat mortality score of 0.3 and puts you in stat category 2. Next slide. So now these two primary procedures codes or combo codes will move forward to determine primary procedure. There's no other rules or exceptions that apply here. So the procedure with the highest stat mortality score will be primary. And in this case, that's 5016. Next slide. And you will notice that this now is not going to be listed in your benchmark procedure table. And that is because the combination of those procedures has been determined to have different, potentially different outcomes or represent more risk and more complexity than the VSD itself. So we don't want to compare that to more kind of standard, for lack of a better term, VSD repairs. Next slide. It's also not listed in the lesion specific table. Again, this looks at primary diagnosis as well, but say you had VSD, the type as your diagnosis and then your procedure, it would not appear in this table. Next slide. But to look at this a different way, say the data manager had only coded 5001, the VSD repair and the ASD repair, and then separately the conduit reoperation. In this case, then the algorithm is going to select 5001 because it has the highest stat mortality score without any other rules and exceptions. Next slide. And now this would be included in your benchmark. It also would be in your stat report, I can't remember if it's table 18 or 19, but how we delineate by stat category. It will be in there as well, but as a stat 1, not a stat 2. Next slide. And then again, could be in your lesion specific table as well. Next slide. Oh, don't forget, because it's based on your primary diagnosis as well as your procedure. So it could be there, but that does have multiple criteria for this table. Next slide. Okay, another example. So this is going to be when we have a tiebreaker. And in this example, we're going to have a combination code as well as a tiebreaker. So we wanted to kind of go through what that looks like. This data manager has submitted a PFO 10, 30 for the ASD repair, and 260 for the partial veins repair. And they've selected partial veins repair as their primary procedure because in the event of a tie, the data manager can choose. Next slide. Again, just plugging the analysis overview, that is here. If there's a tie for highest stat mortality, the procedure indicated as primary by the participant will become the primary procedure. So like I said, they've selected 260. Next slide. However, the individual components are submitted and then it flags and says, hey, these two actually make up combo code 2110, ASD repair plus partial veins repair. Next slide. So now when determining primary procedure, all they're looking at is 2110 and 10. And in this case, there's no longer a primary procedure designated by the participant. And so we have to have some method for picking that out. In the case of a tie, when the data manager has not selected a primary procedure. The way that that is done is by using Appendix C. So Appendix C in totality is a list of procedures with stat mortality scores lined up from least risk, least complexity, all the way to most risk at the end. So if we take the opposite of that, it then goes backwards from most risky to least risky. So in the event of a tie, look at the stat mortality score. In this case, it's 0.1. And working backwards, we're going to find the procedure, the first one that comes up. Next slide. And in that case, it's number 10, the PFO, because that comes before 2110. So again, thinking of all of Appendix C listed from least to most, then going backwards, it's most down to least. So we're going to work backwards through each category. The first one that comes up then, in theory, is more risky. So this will pick out 10 and not 2110. Next slide. 10. So you'll see this in your procedure mismatch report, and it'll say, hey, we want you to pick 10 instead of 260. And you'll probably say, that's crazy. So you'll go look at your case and you can change it. You don't have to just blindly say, I'll take whatever they picked. You don't have to just go with 10. You can change it to 2110. And in all likelihood, you saw that warning when you were submitting data already, and you probably made that decision. But in case you didn't, and if you changed nothing, in analysis, this will be analyzed as a PFO closure. Next slide. Okay, another example, this data manager is coded 10 for a PFO, 460 for a tricuspid valvuloplasty, and 180 for an intermediate AV canal repair. They have selected the tricuspid valvuloplasty as primary because it had the highest stat mortality score. Next slide. But using our new rules, we can see that 180 is listed here in column B and 460 is in column C. And so 460 cannot be the primary procedure over 180. 180 would be the primary, but there are other procedures coded. So next slide. So in this case, it cannot be 460, meaning now there's no primary procedure determined by the data manager. We're looking at 10 and 180, and those are tied. And in the event of a tie, we're going to go backwards through Appendix C, and we're going to get to 10 before we get to 180. So in your primary procedure mismatch report, initially you would see this saying, you have 460, we want you to change it to 10. But it is a tie, and you can choose 180. It's just important to understand that there's not a human looking at every list of codes. It doesn't come through us and we don't look at it and say, oh, I think that should be 180, pick 180. We had to program something to pick a primary procedure in the event of a tie, and this is the strategy. So you can go in and change it to 180, resubmit, perfectly fine. But we did want to explain a little more of how this works. Okay, next slide. Very similar example here. 10 for PFO, 460 for tricuspid, and 190 for partial AV canal repair. Again, the data manager has selected tricuspid valvuloplasty because it was the highest mortality score. Next slide. Maybe. There we go. But we know 460 cannot be the primary. So now there's not a primary procedure determined by the data manager. And this time it's going to pick 190 because it gets there before it hits 10. So I wanted to review this one in particular because when you see this whole list of mismatches, you might see sometimes 190s picked and sometimes 10 over 180. And of course, when you have your clinical hat on looking at this, you would be able to say, oh, I want 190 or I want 180. I definitely don't want 10. But this is the way it works out when nothing is determined by the data manager. So just keep that in mind when you're reviewing, especially when you have just kind of weird things that don't make sense. Look into these ties. Next slide. Okay, to recap, combination codes, whether you enter them or they're derived from individual codes, you're going to code all components as well as the combination code. That is going to ensure that you get the most possible combination codes and then ultimately the most appropriate primary procedure code with as appropriately high a stat score as well as meeting the correct tables and then benchmarking and comparing that procedure to like operations. More details on that can be found in the analysis overview beginning on page 34. And then for tiebreakers, this is kind of a vanishing problem because normally you would have already picked a tiebreaker. Right now we're seeing all 4 years worth of our data being reapplied. So we're seeing a little bit more ties than we normally would going forward. So in the cases where it's not determined by the participant, use Appendix C in reverse. And that'll help explain a little bit about why IQVIA is telling you one thing over another. You can still pick what you want and resubmit. And then just make sure when you're reviewing those mismatches, if it is in the case of a tie, ensure that the component of the tie that you want is selected so that you know what your primary procedure will be and which tables it will fall into, assuming it will fall into a table. Okay, I think that wraps it up for me.
That does. Thank you, Chas Leslie. That was phenomenal as usual. We have lots of questions or several questions, but I did see Tracy has had her hand raised for a while, so I just wanted to start with her. Tracy, did you want to go ahead and ask your question? You may have to unmute on your end if you had a question.
I'm
Hi, Tracy.
sorry, if I had my hand raised, it wasn't, sorry.
That's okay. Nope. It's nice to hear your voice though. So thank you. All right. Okay. Let's tackle our questions. Our first question from Angie. So is Leslie saying that if you select a combo code and it's not the highest stat combo, the software will not take the combo apart and reassign it the highest stat combo code?
Yeah, I think I understand this. Angie, just raise your hand or chime in if I'm not saying this correctly. But if you were to only code combo codes and not code any components of those codes, there is nothing that will break that down and reassign for all possible combination codes. That is why we ask you to code the combo itself as well as the individual components. Okay, Angie, to follow up, yes, is it better to code all separately, upload to IQVIA, and recode based on the primary procedure mismatch? The best practice, what we really ideally want is for people to code all individual component procedures as well as the combos. Pick the as you're going through it, you're probably picking a primary procedure to the best of your ability anyway. You may update that in the future if you got a mismatch. And then if you do, then yes, resubmit it. But I think the best, I mean, that technique, just code everything separate, submit, see what comes out as your procedure, that will work. But if you're not submitting your cases every single day, that would probably get cumbersome. So best practice, code all individual as well as applicable combo codes.
Excellent. Next question from Abby. For the combination 5012, the Norwood procedure plus valvuloplasty, systemic AV valve plus conduit, placement RB to PA, do we still have to have the source of pulmonary blood flow as a secondary procedure?
So that if you only coded the combination code, it includes your source of pulmonary blood flow. But best practice again would be to code the 5012, but also code the Norwood and the AV valve and the Sano shunt. And that Sano shunt then is your source of primary or pulmonary blood flow.
All right. And I think you answered Mary's question. So preferred to list all the procedures performed. Is it preferred to just list all the procedures performed and let IQVIA pick the potential combo code possibilities?
I think that does add a little bit of work to the data manager's plate if that's the way it's done. But if that works for you and you submit often, go for it.
Yeah. Angie, so the score is important, not just the category.
Great question, Angie. Absolutely. The score is what is used, not just the category. So if you have two stat 1 procedures, but one has a mortality score of 0.1 and the other is a stat mortality score of 0.2, the 0.2 is higher and therefore primary unless it meets one of the other exceptions.
Right. So in some situations, it's better to assign a combo code, and in others, it's better to allow IQVIA to do it if you are trying to match locally your benchmark and lesion-specific operations.
Okay. So I think in all situations, it's best to have individual components as well as your combination code. There are a lot of combination codes and there are a lot of individual components, so it is possible that you miss one. That's okay. That's the whole purpose of submitting to IQVIA and going through that report. But I don't think there are some times to do it one way and sometimes to do it the other way. I think it's best to keep it consistent, try to code all at once, and then see what comes out in your primary procedure mismatch report. Update your local data. That's recommended. You don't have to, but definitely if you're trying to match those reports, update your local data and resubmit. Even if you decide not to update your local data, whatever that primary procedure report says your primary procedure should be, that is ultimately what is getting analyzed and will put you in or out of tables. So I personally think best practice is to always list everything and then update to match what IQVIA is pointing out. That way I know I have locally what they're going to do.
Question from Mary. I was recently told that Epic is integrated with health insurance entities and contains patient status alive, deceased in real time. Is that true?
Interesting.
Yeah, I don't know.
I don't know. It's not, I don't see that in my version of Epic, but that, I don't know.
Sorry, we don't have more info. Can you clarify what you mean that it hit 10 first?
Oh, yeah.
So
So
I,
if it was, yeah, you want to go back to, I don't remember what slide it is. That's perfect. If you line these procedures up in order, which it appears in Appendix C, and we're going backwards through each score, it just got to that number first. So I think it's not this example, but the other one.
hold on.
When you
sorry.
have, that's okay. Yep. So we have two procedure codes that we're looking to break a tie, 10 and 180. And when you start at the bottom of the stat score 0.1 list and work your way up, the first one that you come to is 10. And so that's what IQVIA is picking out.
Let's see. Will IQVIA and the mismatch report identify tiebreakers based on determining procedure based on Appendix C in reverse order? Yes.
Yes.
Question about database discharge. I have 3 patients transferred to another acute care facility, therefore missing database discharge date. Can you think of a reason why only 1 patient would flag in IQVIA as missing database discharge instead of all 3 of them?
The only thing I could think of is if you ran the missing variable reports by index operation only and not all of them were index operations. But otherwise, all of them should show up as missing database discharge if everything else is completed appropriately.
Yeah. Okay. Have you seen this happen with the Glenn, I can't talk. Glenn PA reconstruction combo code at all? In other words, should I go back through my cases and code these procedures individually? I've been deleting the PA reconstruction on these cases.
I haven't seen that question come in. We based this talk just on questions that were coming in using this report. I didn't see anything come in, but again, if you have the Glenn, like the type of Glenn, and then the type of PA reconstruction listed, and then also the combo code, it's only going to consider the combo when determining primary procedure. So I don't think you have to go back. As long as it looks like it's appropriate, like if you look at your primary procedure mismatch and it's not picking out anything, then I think it's fine.
Diane, Leslie, in your example of the PFO closure and the partial AVSD, closure, that word's high. If we put the partial closure as primary, will IQVIA keep it as primary and therefore it will be in the lesion specific table?
Yes. So only because we have all of these new rules being applied at the same time. So in that example, for instance, if they had the tricuspid valvuloplasty, that used to be allowable, and so that would have been primary. Now we have that included in the exceptions list. So now it cannot be primary. And because it cannot be primary, we're left with two codes and neither one were identified by the data manager as primary. So it is suggesting PFO. If you go back in and say, nope, I want AVSD and resubmit, IQVIA no longer has a problem. It doesn't see a tie because you've identified something then. So you're fine. And then as long as all other criteria match, it gets to the tables that you expect.
So in other words, Leslie, what you're saying is if you notice the mismatches, if you match your data and or select something else that was tied with that procedure, everything is fine. It's not going to go to an incorrect procedure upon analysis.
Correct.
For procedure code 1125 arterial switch procedure and VSD repair plus aortic arch repair, which is a combo code, we also code all the individual codes. Example, the arch repair, the VSD repair. IQVIA then tells us to code aortic arch repair plus VSD repair, but this seems redundant, so I do not add this code. Are you recommending that we should add all eligible combo codes as well?
Yeah, that's a great question. That one is a little bit different than all of the others because it's looking for all possible combinations. So you have like this 3-part combination, but then you have 2 parts this way and 2 parts that way and A plus C. It's just pointing that out to you. You do not have to update that if you don't want. It just is a glitch with that particular group of procedures. If it makes you feel better, certainly go ahead and do it. It'll clear the warning. But you're still, in that case, going to get that like larger 3-part combo.
To piggyback on Mary's question about Epic and 30-day discharge proof of life, can we use whether insurance, Medicare, Medicaid is active to accept that patient is still alive? We've exhausted all other attempts to track down patient, provider contact, patient phone number, and emails, etc.
Yeah, Tracy, I saw your FAQ come in this morning as well. As far as I know right now, that is just saying that there is no proof of death. And that's not acceptable to say that there is life. I have that question flagged so we can talk about it more with the core group, but just right now off the cuff, I don't think that that qualifies.
Brooke was saying she was seeing the same in her data as Tiffany. What if 180 days has elapsed? Could that be the difference among the 3 database discharge cases? Oh,
The
what if?
missing variable report doesn't know that the patient has or hasn't survived for 183 days on chronic care status, without readmissions and things like that. So it's not using that 183-day rule at all. I'd be interested to see how everything is coded and then what filters you're using in IQVIA. All of mine have shown up appropriately, so I'm just trying to think through it, and I don't have it open
Yeah.
at the moment to give examples, but.
Yeah, Tiffany was just saying patients were discharged, one in December, one in January, one in February. Yeah. We would have to go in and look at it. I don't
Well,
know.
the ones that discharged in January and February, because your data is only through December 24.
Okay, yeah, Tiffany. Yeah, okay, so she asked today. Okay, yeah, we'll look into it, Tiffany.
That sounds good.
Yeah, because yeah, I'll have to go in and have IQVIA look at it. Once I call from Shauna, once I code all the individual components and the combo codes, I will get my mismatch report back. I then correct my coding. Do I delete the individual components at that time if they are part of the final combo code, or do I leave all individual and combo codes? Is this double coding?
Great question. Please do not delete the individual combo codes. That is because we want to see that in the future. Right now, we are working with the procedure codes and combinations that we have available. But it is possible that our surgeons want to look at this data again and they want to say, okay, this combination code, when done with this individual procedure, now is even higher, it's even riskier, there's other things going on. So really, they want all of those individual codes as well as the combo, so that one, we have the appropriate primary procedure, but two, it allows us to look at multiple different ways of combining these to see what really makes a difference in the patient's outcomes.
Excellent. All right, recently we had a 2-year-old with, I don't know what DCM is, and a bad experience. An acute, okay. I'm not clinical, so help me out here, Chas.
Okay. Recently
right.
had a 2-year-old with dilated cardiomyopathy and a bad experience an acute right embolic stroke on the evening of 3/10. He was then sent to another hospital 3/11 late at night. They attempted an aspiration thrombectomy, which was unsuccessful. He came back on 3/12 in the evening. The terms were mostly discharge admitted, but was it in fact a transfer in and out? So a new encounter, but not a new admission. Nancy, there's a lot to this question, but the episode of care will remain the same. Perhaps this is probably best to submit to the FAQ box, and then we can go let us know which fields that you have in question,
Yep, perfect.
and then we can help you fill out everything correctly.
Yeah, thanks for saving me
Great
that, Chas.
question, though.
Yeah. Thanks. All right, next question from Abby. 1285 aortic arch repair plus VSD repair has a score of 2.4 of category 2,
Category
plus
2, yep.
1.4, but an aortic arch repair on its own 1280 has a score of 3 and 0.5. If we enter all components, we would then make the aortic arch repair the primary because the score is higher than the combo.
So Abby, no. In your software, it's going to look like that, especially if you have your stat scores displayed. But aortic arch repair is a component of 1285 aortic arch repair plus VSD. So ultimately, your individual codes will be flagged with the combo code 1285, and the individual components will be ignored when determining primary procedure. So in this case, it'll be, you have 1285 listed and then 1280 and then whatever type of VSD repair. Those latter two, the 1280 and the VSD repair, will be ignored, and 1285 is still going to be primary procedure. This is kind of a wonky one. We get this question a lot, but when the data was broken down, the patients who had a combination of an aortic arch with a VSD for whatever reason had slightly better outcomes. It was determined to be a slightly riskier altogether operation than when you're doing an arch repair on its own. So it does seem odd because the component, part of it was higher score than the whole combination, but it just is what it is based on the data.
Perfect. All right, Jen, making sure patients with surgery in 24 and are discharged in 25, are they included in this harvest? Does harvest go by surgery date or discharge date? So
Thank you for this question, Jen.
Yeah, go
This
ahead.
is definitely by surgery date. And so January 1 of 2021 through December 3rd, surgery dates that occur within January 1 of 2021 through December 31st of 2024. Regardless of, they get discharged today, they would still be included if their index surgical operation occurred during the 4-year time frame. I was trying to think through what people are seeing in the IQVIA reports and didn't know if the date of discharge had anything to do with perhaps what reports you're looking at within IQVIA. But thank you for that question.
Great question. All right, thanks, Chas. Leslie. No other questions at this time. Real quick, our next monthly webinars, our April 15th webinar is scheduled for 12 p.m. Central. We will be doing the data manager survey next month, so please, we do encourage you to attend so we can get as many people attending and responding to that data manager survey. We get a lot of requests for the data manager survey for information on FTEs, how much time it typically takes to abstract cases, things like that. So we would encourage you, please do attend next month's monthly webinar. And in addition, Chastity and Leslie will still also be providing additional education next month as well. And then our May webinar is scheduled for May 20th. Angie has a question. So do you submit all cases even though not yet discharged?
Yes, absolutely. All cases that occur in that 4-year window, index or otherwise, discharged or otherwise, all get submitted.
Yes, thank you. Great question, Angie. Let's see, Ren, April date conflicts with the PC4 spring conference. Oh,
I thought,
okay. Yeah, I think
didn't you say April 4th?
as April 15.
Oh, I'm sorry, April 15th.
Yeah, April 15. Okay, thanks, Ren, for letting us know. Yeah, okay. I'll talk to Carol, but I think we'll still keep our webinars on the 15th, but it'll still be the 15th and but thank you for letting us know. All right, any other questions? I'm not seeing any other questions. As always, our contact information is included at the last slide. Please feel free to continue reaching out to tech support, STSDB_helpdesk at sts.org for all of those uploader related questions. So yes, please continue to reach out to STSDB_helpdesk. Jen has one question, Chas Leslie, how to handle long-term complications if they are still in-house?
Great. What I do is I just collect them as they occur prior to submitting for harvest. If that patient is still in-house or in another house, another hospital, they ultimately will not go into analysis or into any of the tables where complications and post-op or intraoperative events are reported until they have a database discharge date. And at that time, you would then have your completed case and your completed list of all complications and events. So that's best I can do. Like I keep track of them as best I can throughout the admission, knowing that it's not fully complete until after the patient goes home or it's 30 days post-op or they otherwise get out of the database, however that happens.
Thank you. All right. We are officially at the hour. I'm not seeing any other questions come in. So thank you, Chas Leslie, for providing our phenomenal education as always. We appreciate it very much. I know there's lots of questions that have been coming in. If you all have any additional questions, please feel free to reach out. Just a reminder, any clinical questions should be submitted to the FAQ using the FAQ clinical question submission form. Also, report-related questions should go to STSDB_helpdesk at sts.org. So thanks everyone for joining today. We appreciate it. Thank you. I see Dr. Meyer snuck in on us. So thanks for joining, Dr. Meyer. We appreciate you being here. And I hope you guys have a great rest of your day. Thanks so much, everyone.